Hi, myself Dr. Sandeep, physician from China General Hospital. Today, I am going to discuss about respiratory system, in which I am going to discuss about history, cough symptom. Definition: cough is defined as sudden and variable expiratory thrust of air from the lungs through air passages against previously closed glottis associated with phonation which interrupts momentarily the physiological pattern of breathing. The function of the cough: it is a defense mechanism which keeps the respiratory tract clear, protects from foreign body, and prevents stagnation of secretions within air passages, which helps to prevent infection. Etiology. Etiology of cough. There are seven main headings you need to remember in etiology. My first is infection or inflammation of the respiratory tract. It might be acute or chronic laryngitis, tracheitis, bronchitis, or acute bronchiolitis, or acute pneumonia, or a chronic PTP and chronic pneumonia. Mechanical irritations due to foreign body or smoke or dust particles such as pneumoconiosis, which might be due to organic or inorganic, and chronic sinusitis. Next is chronic sinusitis. There is a postnasal drip which can cause cough. And third important cause is bronchogenic carcinoma. Fourth is extrapulmonary causes. These induce cough through pressure on respiratory structures such as trachea or bronchus, or penetration or infiltration of respiratory tract. Secondary involvement of the lung parenchyma due to increased LA pressures, such as aortic aneurysm, mitral stenosis, dilated cardiomyopathy, mediastinal lymphadenopathy, LV failure, disease of pleura, diaphragm, and O'Tner syndrome. Fourth is reflex causes. This induce cough by irritating vagus nerve, example foreign body or vaccine auditory meatus. Fifth is psychogenic cough, and and seventh is drug induced, such as ACE inhibitors, beta blockers, and amiodarone. What is O'Tner syndrome? O'Tner syndrome is also known as cardiovocal syndrome. It is mainly there is a recurrent laryngeal nerve compression due to enlarged cardiovascular structures. Most common cause is due to enlarged left atrium due to mitral stenosis and pulmonary hypertension, followed by thoracic artery aneurysm, enlarged pulmonary artery, and aberrant subclavian artery. And this is the pathway of the cough. There will be a stimulus in the form of pressure, inflammation, or mechanical irritation, which stimulates sensory nerves in the mucosa of the pharynx, larynx, trachea, and bronchi. And an afferent impulse is sent via ninth and 10th cranial nerve. There is a cough center in medulla, which sends an afferent impulse via 10th cranial nerve, supplying abdominal muscles and intercostal muscles. Then there is a cough reflex. Method of inquiry. First, we need to ask for the duration of the cough. Acute cough is defined as less than 3 weeks. So, acute upper and lower respiratory tract infection, exacerbation of chronic obstructive pulmonary disease, asthma, allergic rhinitis, congestive heart failure, pneumonia, aspiration, pulmonary embolism. These are the causes of acute cause. In pediatric population, most common cause is pneumonia, foreign body aspiration. Subacute is from 3 to 8 weeks, such as post-infectious cough and tuberculosis. Chronic causes are most commonly pulmonary tuberculosis, asthma, upper airway cough syndrome, GERD, cough variant asthma, cough inducing medications, or psychogenic or idiopathic cough, or cough of cardiac origin. In India, more than cough with for than more than 2 weeks with sputum, rouleau, tuberculosis. Next is type of cough, whether it is a productive or non-productive. Productive means it is with sputum, and sputum will be explained later. And dry cough, it is seen in pleural disorders, interstitial lung disease, mediastinal lesions, and upper respiratory tract infection. So this is a table showing a few characteristics of cough. In asthma, the cough is more worsened in night, and there will be history of allergy and history of chest tightness in child, and it is relieved by bronchodilators such as salbutamol. In COPD, it is a long-standing cough, and it is more in early morning. In rhinosinusitis, there is a trickling sensation, that is a postnasal drip will be present, And in sinusitis, there will be a frontal headache and nasal discharge. Next is in GRD, the reflex symptoms is more in the night time. It induces mainly a nocturnal cough, and it is relieved by using a proton pump inhibitors. In laryngeal hypersensitivity, is a irritating cough. It is a tickling type of cough associated with voice disturbances and cough precipitated by talking. Other causes such as lung cancer, most common cause is presented cough followed by breathlessness, and hemoptysis is most of the times is present. In bronchiectasis, there is a very large quantity of sputum production associated with cough, and in eosinophilic bronchitis, there will be recurrent attacks of wheeze. Next is character of cough. A short cough is commonly seen in upper respiratory tract infections. A brassy cough, that is a metallic type of sound, it is produced by compression of trachea by intrathoracic space occupying lesions. Next is a bovine cough. Bovine cough means there will be loss of explosive nature of the cough. That is mainly due to neuromuscular weakness or a recurrent laryngeal nerve palsy, most commonly. That is a cardiovocal syndrome causes or Wharton syndrome causes, which have been explained earlier. It is a prolonged cough is seen in chronic bronchitis due to the bronchoconstriction. The duration of the cough episode will be prolonged. And in paroxysmal cough, it is seen characteristically in whooping cough. And a barking cough is seen in epiglottitis. And coexistence with stridor suggests obstruction of the upper airways, whereas coexistence with wheeze suggests obstruction of the lower airways seen in bronchial asthma, chronic bronchitis, and tropical eosinophilia. And associated features must be asked, such as breathlessness, chest pain, fever must be asked. So, any acute onset of the breathlessness, we need to think of the five causes, such as acute pulmonary embolism, foreign body, bronchial asthma, pneumothorax. So these are the common causes which we need to suspect in a acute LVF, in acute breathlessness causes. When it is associated with chest pain, based on the characteristic of chest pain, we should rule out pneumonia, pleurisy, and pulmonary thromboembolism. And if dysphagia might occur due to the lesions compressing the esophagus as well as the trachea, they will be associated with cough with dysphagia. And change of voice occurs due to pressure on trachea or main bronchus due to recurrent laryngeal nerve involvement. Associated with fever in TB, pneumonia, lung abscess, and upper respiratory tract infections. What is called as cough syncope, a chronic airway obstruction such as COPD, increases intrathoracic pressure, which in turn decreases the cerebral blood flow, which might result in a cough syncope. This is a type of a vasovagal syncope. And we need to ask with the relationship with meals, that is food intake. It increases a debilitation in a developmental anomaly such as bronchoesophageal fistula and tracheoesophageal fistula. And also it increases after meals in chronic lung disease. Next question we need to ask is positional variation of the cough. Patient prefers to lie on ipsilateral sides in pleurisy and pleural effusion so that the healthy lung can be better ventilated. Whereas the patient prefers to lie on the contralateral side as postural drainage of mucus into healthy bronchi stimulates cough. So it is seen in lung abscess and bronchiectasis. And patients prefers to sit in LVF as because LVF is associated with orthopnea, and in COPD patient prefers a tripod position, and in also in diaphragmatic hernia the herniation of the contents increases in lying down position, so they prefer sitting position. Next is diurnal variation. In COPD, the cough is more in early morning in COPD, pulmonary tuberculosis, bronchiectasis, where it is cough is predominantly nocturnal in asthma, pulmonary edema, diaphragmatic hernia, and GERD also. Nocturnal cough is very common. Aggravating factors. We need to ask an history of aggravating factors such as exposures to allergens such as dust, animals, pollen, or an environmental triggers we need to ask. Next is what are the red flag signs of cough? The red flag signs of cough are hemoptysis, dyspnea, weight loss, fever, sore throat, tuberculosis, immunosuppressive state, and cough more than 35 years of age in patients with more than smoker's cough and cough syncope. So, what are the recommendations for differential diagnosis and treatment of the cough? See, all cough doesn't require an aggressive investigations unless it is associated with red flag signs or duration more than 2 weeks. In India, cough with sputum more than 2 weeks, we need to rule out always pulmonary tuberculosis. But when there are no red flag signs or the duration is of less than 2 weeks and the history and examination are normal, then patient can be treated with empirically. The most common causes are cough variant asthma and GERD. In the cough variant asthma, the treatment is mainly symptomatic. In GERD, the patient will be treated with proton pump inhibitors. When the cough is persisting, we need to go for advanced investigations such as lung function tests, spirometry, and other investigations. A cough of cardiac origin must be suspected when there is a history of cardiac illness or an orthopnea, dyspnea, or examination signs such as pedal edema, raised JVP, S3 galloprhythm, or a use of angiotensin converting enzyme inhibitors, beta blockers, and the amiodarone. Environmental factors should be considered regarding the uh, place of residence and occupational history. Any neonatal cough until an etiology is established, we should suspect for pneumonia. And in pediatric patients, if foreign body aspiration is suspected, a referral for bronchoscopy is an immediate indication. And this is the basic investigation. So first we need to check the saturation, get an ECG, X-ray, ABG. Then we might go for the advanced investigations such as CT and pulmonary function test. And the treatment is mainly treat the cause, and cough suppressants such as codeine, dextromethorphan, benzoate, and levetiracetam is used. And cough suppressants must be used in hemoptysis uh, to decrease the effect of to decrease hemoptysis. And there are off-label drugs such as gabapentin and amitriptyline also can be used, but it is not approved. And now the research is undergoing for using the targeting the novel targets such as neurokinin receptor antagonist and type 1 vanilloid receptor antagonist. And after this presentation, you see a brief video on the character of cough about for 3 minutes. Thank you.